So let's start with a chronic obstructive pulmonary disease, COPD, which includes emphysema and chronic bronchitis. This slide compares chronic bronchitis and emphysema in different aspects. The first one is the anatomic distribution. Chronic bronchitis initially involves the large airways, whereas emphysema affects the sinus. However, in severe cases of both, small airway disease is present and is called chronic bronchiolitis. And because cigarette smoking is the major underlying cause of both diseases, they tend to coexist. However, both can present alone, like in cases of pure emphysema in cases of inherited alpha-1 antitrypsin deficiency. The second aspect is the morphology. Both diseases are irreversible, especially if compared with asthma. Regarding the definition, emphysema is defined on the basis of morphologic and radiologic features, whereas chronic bronchitis is defined on the basis of clinical features. Emphysema is defined as a permanent or irreversible enlargement of air spaces distal to the terminal bronchioles, with destruction of their walls and without significant fibrosis. So the part that is affected by the irreversible damage is the sinus. Emphysema can be classified according to its anatomic distribution into the following types: centri-acinar emphysema, pan-acinar emphysema, distal acinar emphysema, and irregular emphysema. However, the significant airway obstruction is associated mainly with the centri-acinar and pan-acinar types. Figure A shows the normal structure of the sinus, which is considered the fundamental unit of the lung. Pulmonary acini are composed of the respiratory bronchioles, alveolar ducts, and alveolar sacs. Figure B highlights the affected part of the sinus in centri-acinar emphysema. As you can appreciate, the dilation initially affects the respiratory bronchioles, while Figure C shows distension of all the peripheral structures, including the alveolus and the alveolar ducts in pan-acinar emphysema. This disease later may extend to affect the respiratory bronchioles. Centri-acinar or centrilobular emphysema affects the central or the proximal parts of the sinus first, and those are formed by the respiratory bronchioles, while the distal alveoli are spurred. It occurs commonly in cigarette smokers and is often associated with a chronic bronchitis because both are related to cigarette smoking. Regarding the lung involvement, it's more common and severe in the upper lobes, particularly in the apical segments. Pan-acinar emphysema or panlobular emphysema, on the other hand, is called pan-acinar because the acini are uniformly enlarged from the level of respiratory bronchioles to the terminal blind alveoli. It's associated with alpha-1 antitrypsin deficiency. Alpha-1 antitrypsin deficiency is a genetic disorder that may result in lung disease or liver disease. Regarding the involvement of the third type is distal acinar or paraseptal emphysema, which involves the distal portion of the sinus, while the proximal part is normal. Interestingly, those lesions usually present adjacent to the pleura, along the lobular connective tissue septa, and at the margins of the lobules, and adjacent to fibrosis, scarring, or atelectasis. Distal acinar emphysema is more severe in the upper half of the lung. The cause is unknown, and the presence of multiple enlarged air spaces ranging from less than 0.5 mm to more than 2 cm that may form large cystic structures that give rise to bullae. So paraseptal emphysema is the most common cause of spontaneous pneumothorax in young adults. This chest radiography reveals a right pneumothorax with expansion of the right chest cavity and displacement of the heart to the left. Pneumothorax can be caused by penetrating chest injury, inflammation with rupture of a bronchus into the pleura, and rupture of an emphysematous bulla. The fourth type is irregular emphysema. In this type, the acinus is irregularly involved, but almost invariably this type is associated with scarring. Clinically, this type is asymptomatic. However, it's considered the commonest form of emphysema. The classic presentation of a pure emphysema patient with no bronchitis component includes dyspnea or shortness of breath, which is the first symptom. The patient is usually barrel-chested, and this is due to air trapping and lung overinflation. Patients usually experience prolonged expiration, and this is due to the expiratory obstruction. Usually, patients are seen sitting forward in a hunched over position, trying to squeeze the air out of the lungs with each expiratory effort. Hyperventilation is another feature, and that's why in early disease the gas exchange is adequate. And because the oxygenation of the hemoglobin is adequate and the patient shows prominent dyspnea, those patients are called pink puffers. Pink refers to the pink face completion and good oxygenation. Puffer because they experience difficult breathing and breathe through pursed lips during expiration. Other symptoms include cough and wheezing, especially in cases of coexistent chronic bronchitis and asthma. Remember pink puffers. The patient is usually barrel-chested due to air trapping and lung overinflation. Barrel chest. This refers to an increase in the anterior-posterior diameter of the chest wall, resembling the shape of a barrel.